Welcome everyone to the first webinar in a series on human rights and non-communicable diseases in South Africa, organized by the Socio-Economic Rights Project at the Dullah Institute. By means of introduction, my name is Paula Knipe. I'm a doctoral researcher at the Dullah Institute, and I'll be your moderator today. The rise of NCDs has been described as a public health emergency in slow motion and is now the leading cause of mortality, estimated to account for 51% of the country's annual deaths. These diseases of lifestyle have been driven primarily by four major risk factors: tobacco use, physical inactivity, the harmful use of alcohol, and unhealthy diets. Research has shown that diet-related risk factors are now associated with more premature deaths than any other factor. As such, this webinar seeks to explore the link between access to safe and nutritious food and non-communicable diseases in South Africa. This webinar aims to spark meaningful conversation on the right to access to safe and nutritious food and healthcare in South Africa. While these issues have long been on the global agenda, the importance of access to safe and nutritious food and healthcare has been highlighted by the unprecedented COVID-19 pandemic. NCDs, however, have received less than satisfactory consideration as part of the government's response to the pandemic and those with comorbidities. Therefore, today, we seek to explore the proliferation of NCDs magnified by high levels of food inaccessibility and weakening health systems whose resources have been stretched to respond to a myriad of health-related burdens. This webinar aims to provide a platform to identify collective solutions in responding to the increase of diet-related NCDs in South Africa. It equally hopes to extend the conversation to advocacy strategies and diverse approaches in addressing this challenge. The program is as follows: the introduction, which I'm busy with now, and we will then hear from our three panelists, Prof. Rina Swart, who will talk us through the extent of diet-related NCDs in South Africa, what is the nutrition transition, and how are consumption habits perpetuating NCDs. We'll then hear from Dr. Jane Battersby, who will provide some context on the food environment in South Africa, making the link between urban food policy and NCDs in a post-pandemic era. And third but not least, we will hear from Dr. Vicki Pinkney-Atkinson, who will guide us on advocating for effective NCDs policy and implementation in South Africa, what CSOs should know. We'll then have a 20-minute question and answer session, and then the closing remarks by my colleague Gladys Makundi. A few housekeeping rules before we proceed. Please familiarize yourself with the mute and unmute button. Panelists, please unmute yourself to present. To the participants, please ask all questions in the chat and direct them to the speaker if possible. These questions will be repeated during the Q&A. Please only raise your hand if urgent. We are using only audio today as it seems to allow for the best communication. For the speakers, please maximize your 15 minutes for your presentation. And for purposes of timekeeping, if necessary, I'll remind you when you have 2 more minutes left. Please note that this webinar will be recorded. Thank you for joining us today, and we're looking forward to a meaningful engagement on this issue. So without saying much more, may I please welcome our first speaker, Prof. Rina Swart, who is a professor in the Department of Dietetics and Nutrition at the University of the Western Cape. She's a registered dietitian with specialization in public health nutrition, a registered nutritionist with the Health Professions Council South Africa, and also serves as the lead for nutrition in the DSI-NRF Center of Excellence in Food Security. Prof. Swart, you have 15 minutes to take us through your presentation. The floor is yours.
Thank you very much. Can I just double check you can hear me well?
We can hear you and see your presentation.
Thank you. Thank you very much for the invitation to participate, and greetings to all who have joined this webinar. It is definitely a pleasure and a privilege to share some information on non-communicable diseases in South Africa, the nutrition transition, and how the foods we consume contribute to both. As an introduction, I just want to mention some of the data and actually the data gaps that we have This appears to be a very long list of data, but often the methodologies are different. The groups are different, so you can't necessarily compare all of them. May I just take a moment to point out the two items that are highlighted in blue down the list, and those are two surveys that will be taking place, COVID permitting, in 2021. One is currently has already started on food and nutrition security, and then we will be doing another South African dietary intake survey later this year. Let me start by saying that the food we eat, as well as the consequences of the food we eat, are all part of a very complex set of conditions and circumstances, and all of them are interlinked. Undernutrition and obesity may appear to be on two different things, but they're actually on things on the side of the same coin, because although undernutrition is because of a lack of food, and often people think obesity is excessive food, some of the root causes in terms of the context of poverty and unemployment results in choices being made that actually feeds both. And the same applies, for example, with HIV, where many of the poverty-related conditions that would be driving HIV are then contributing when treatment for HIV is successful, and the person may develop obesity and or NCDs as a result of metabolic changes and fat deposits and all of that. Now, most of the upstream drivers of these conditions are actually the result of our specific South African context. Poverty, unemployment, hunger and food insecurity, inequalities, as well as the commercial determinants of health. Maybe just in a nutshell, let me quickly remind you that we're talking about continuing poverty, where 55% of the population live below the upper poverty line and 25% of the population live below the food poverty line. I'll speak again later about nutritious diet for children that actually cost more than the food poverty line and cost much more than our current child support grants. We live in a situation of extreme inequalities, with 60% of the population having access to only 7% of wealth in the country. We have persistent and rising food insecurity, and given the COVID-19 situation, that has even increased, and it is combined with continuing profit-driven commercial determinants of disease. And I mentioned some of the cost of nutritious diets, for example, for a child being a minimum of 710 Rand, and you saw in the previous slide the food poverty line that is more than that. So what is the current scenario with regards to non-communicable diseases? Overall, non-communicable diseases, and that include all cancers, cardiovascular disease, diabetes, chronic respiratory disease, high blood pressure related conditions, and obesity, to name a few, accounts for 51% of all deaths in South Africa, with then 40% communicable disease, maternal and perinatal diseases, as well as the nutritional conditions and injuries being a small component. A review, the second burden of disease study in South Africa analyzed mortality data and clearly illustrates the success we had with obesity treatment since 2005. So in this slide, you will see down at the bottom, the pink or purple being nutrition-related perinatal conditions, the red being HIV, the blue non-communicable diseases, and then the green part represents injuries. If we look at the same information in a different, presented in a different way, you'll see that since the success in HIV, the numbers of people that die as a result of non-communicable diseases actually exceed that of HIV. However, if you were to look at the budget available and the funds being spent on NCDs and specifically diet-related non-communicable diseases, then it is very clear that this is not receiving the attention or the resources required for it. But people do not only die from non-communicable diseases, they live with it. And COVID provided a very key example to look at this. If you see each of the gray circles as the total number of people hospitalized within each of the age brackets, the blue circle on the slide represents people who have non-communicable diseases as a comorbidity. The red circle, those with HIV, and the green circle, those with tuberculosis. So it is very clear that obesity and non-communicable diseases result in significant cost, not only for individuals in terms of their economic productivity, but also in terms of healthcare within the country. Now, how does this tie in with non-communicable, with the nutrition transition? These are some of the risk factors for non-communicable diseases, and they're also part of the nutrition transition. So I'll move on to obesity specifically, which is now also been seen as a disease in its own. I highlight the South African picture amongst that of other countries in the world. And you'll see that the rate of increase in South Africa has been particularly steep for women, which is the red line on top, as well as for men, but more so for children, the pink and blue line at the bottom, if you look at that very, very sharp increase. Over the last 10 years, the rate of obesity in children has increased from 1 in 20 to 1 in 8 children. That only in a period of 10 years. And it is estimated that by 2030, if we continue at this rate, at least 3 out of every 5 children will be obese. This is of particular concern for 2 reasons. We know that treating obesity through weight loss is extremely difficult, and specifically to maintain that weight loss over time, research has shown that less than 1 out of 5 people manage to maintain weight loss for 5 years post the weight loss period. So in this case, it's definitely a matter of prevention is better than cure. We should protect our children from becoming obese. 7 out of 10 overweight adolescents have been shown to grow up to become obese adults. Now, changes in overweight and obesity has happened over time, and it is part of what we call the nutrition transition. This term was coined by Professor Barry Popkin about 2 or 3 decades ago, after years of surveys in countries such as China, India, and Korea. And it refers to the types of foods consumed by people the ways in which they acquire and consume that food, and the subsequent consequences in terms of ill health, disease, and death. There are several transitions, and all of them are again interdependent and linked. Earlier on, it was thought that these transitions follow a very specific pathway. But as the rate of change has increased, it becomes very much a chicken and egg situation, and each one impact on everyone, every one of the other transitions. So how has the South African diet changed as a result of these transitions? My generation may remember the picture on the left with fields and orchards growing food. I think the younger generation, the supermarket shelves and brand names, images on the right-hand side, may be their recollection of food sources. The result of this is that the dietary diversity of South Africans is extremely limited. Only 1 in 10 people consume 8 or more of the different food groups, and those people are primarily in the highest income deciles, which is the column on the right-hand side. The expenditure on these food items or these food categories also confirm our food consumption patterns. And when I compare the deciles of intake, the deciles of expenditure, you'll see that something like fruit, on which not significant amounts of money is spent in all of the groups, but it's in high income deciles at least 19 times more than what it is in the lowest income decile. The expenditure on meat is 6 times higher than that in low income deciles, and also in terms of vegetables, they spent significantly more in the high income decile compared to the lower income deciles. And you can see it's round about the 5th decile that there's a change in the consumption pattern. These changes does not necessarily happen equally within each of these food groups, and I'll get to that later, but maybe I should just illustrate again the different food groups and the consumption and how it has changed over time. Now you'll see that this appears as if there has not been much change within specific food groups. There are some, and specifically sugar, the purple one close to the bottom, where there has been some changes, and also in the pulses there's been some change. So what has happened within these different food groups? I consulted other data, and that's specifically by Euromonitor. So over the period 2005 to 2019, so the previous data that you saw, that is what we know from records, self-reported expenditure by households. This is based on sales within the country. And the numbers that you see within each year represents the amount of that particular category of food being consumed per person per year, in kilograms mostly, or in volume. So this would translate into 24 kilograms of fruit per person per year. If you look and you see there are very few changes, the difference comes in within food groups. And I've given some of the examples at the bottom. So for example, breakfast cereals, ready-to-eat breakfast cereals, you can see that it has changed significantly over the period from 2005 to 2019. And on the right-hand side, you see sweetened beverages, or beverages, in general, and they include bottled water. And the major change took place in the sweetened beverages, specifically the carbonates and the nectars, the two top lines. So we haven't changed necessarily within food groups that much, but we have definitely changed, or between food groups, we have changed within food groups, the types of foods we choose. And Jane will speak later on obesogenic food environment specifically, but part of this is because of the obesogenic food environment where we purchase our food, majority of our foods from companies. When we look at the nutrient consumption, again, I'm showing those where we have and observed particular challenges, and look at the added sugar line as well as the fiber that's being consumed. The recommendations are in the dotted lines, red for men and women with regards to fiber, and blue for added sugar, which should be less than 25 grams per day per person. And you can see the solid blue line and solid red line, often for fiber being below and for sugar being above those lines. And that's because of the choices we make within specific food groups. So an obesogenic food environment speaks to physical environment, the economic conditions within that, policy actions, as well as socio-cultural norms. And I'm saying this specifically because I want to focus on the last two, so that we think about how
Prof,
much...
apologies, I didn't mean to interrupt, but just 2 more minutes for your...
Yes.
Thanks so much.
Okay, so yes, there are very few policies and regulations that would benefit our environment, and norms. Often we accept what we see. Our food consumption is not good for our environment at all. And therefore, we have to rethink not only the food that we choose, but also our food environment at large. What kinds of foods do we want to have farmers and manufacturers to produce for us? What kinds of foods do we want to see promoted to our children? What kinds of information do we want to have on a product when we have to make the choice? And what kind of information on food and nutrition do we want our children to receive at places of care, such as schools? Each one of us should be empowered to vote with our feet, but also with our purses. Thank you.
Thanks so much, Prof. Swart, for a really extensive and interesting presentation. I'm sure you'll get some questions later. For me, it was very interesting that you enforced how it's not only about preventing people dying from NCDs, but how we, better their lives while living with it. And also a really interesting statistic regarding children and obesity, and that 3 out of 5 children will soon be living with obesity. So thank you so much for that, and we're looking forward to the Q&A later. If you'll please allow me to welcome our next speaker, Dr. Jane Battersby, who is an associate professor at the African Center for Cities and a senior lecturer in the Department of Environmental and Geographical Science at UCT. She has worked on urban food security and food systems in South Africa and the wider continent for over a decade. Dr. Battersby, you have 15 minutes to take us through your presentation. The floor is yours.
Great. Just checking, can you hear me?
We can hear you and see your presentation. Yeah.
Awesome. Great. Thank you, everyone. I'm hoping my voice holds out. Unfortunately, my kids made me sick this week. But picking up on Prof. Swart's presentation, I think it set the ground really nicely for understanding the extent of the problem that we have. And I'm going to take us through some potential urban interventions that might help us move forward with addressing NCDs. I think the title was very hopefully given to me about a post-pandemic world. I don't think we're in a post-pandemic world, but maybe we can start imagining what kind of food system we might want in that kind of world. So let me just try and move these slides forward. Okay, so what we've been working on is saying, this is clearly a problem, and the extent of child obesity and clearly the diabetes, the hypertension, all of those challenges have been brought into sharp relief under COVID. And it's made people think about, well, what are the potential ways to alleviate this? And a lot of the focus nationally has been, do we do health messaging? So at the start of the thing, you spoke about diseases of lifestyle, and is that a helpful framing when actually we're looking at a systemic problem? So it's either been about health messaging or about things like taxing and regulating specific kinds of foodstuffs. So the sugar tax, the kind of salt regulation. But our contention is there's an awful lot of things that happen at the urban scale and within urban governance that could actually fundamentally shape NCD outcomes. And some of these are food system specific and some of them are food system sensitive. And so I'm going to be talking about the food environment, but not just kind of what's being sold and where, but also how people are able to use that food environment. So if you scan back in your mind to think about some of the slides you just saw about this kind of changing diet, this changing disease profile, I want you to hold that in your mind as you look at the next slide, which shows the rapid expansion of supermarkets across Cape Town. And this is a 1994 to 2013 comparison. We haven't produced the updated map yet, but that trend has continued. And you can see this kind of proliferation of supermarkets, first along kind of wealthier areas and then progressively into lower income areas and along transit routes. This is a fundamental shift in our food system. And some people will argue that it's providing better access to higher quality, more diverse foods. And it's certainly doing that, but it's also changing the availability of ultra-processed foods, and it's also changing the kind of very local food environments. So what we're seeing is oftentimes when these new shopping supermarkets arrive, they don't come in the form of a standalone store. They come in the form of a mini shopping mall or a large shopping mall. And there's a kind of common geography to these things. I'm a geographer, so everything's going to be maps, I'm afraid. But there's this common microgeography of these things. If you look at the new malls that have gone in, there's normally a ShopRite as the anchor tenant at the end. And then there's normally 1 or 2 or 3 or 4 fast food chains located nearby. And remembering that Hungry Lion is a subsidiary of ShopRite. And so you're seeing people being channeled increasingly into purchasing from the supermarkets, and that's where you have also been accessing your SASA grants. And then you come out and you then buy the fast food as well. And then you go to OK Furnishers, which is also owned by ShopRite, and get pulled into a formal credit system. So we're seeing the arrival of these malls as fundamentally reshaping local economics, local food availability, local food aspirations. We're not the only people to have noticed this. Otterbeck et al. Have just released a paper using Google data to measure the role of big food and fast food in South Africa's obesity epidemic. And they do a lot of very complex regressions, and their argument is much more complex than supermarkets make people fat. But they do note that proximity to bigger chain supermarkets and fast food restaurants is significantly associated with overweight and obesity. We conclude that big food and fast food are not necessarily the main drivers of the obesity epidemic in South Africa, but they likely contribute to the problem. And so we've got to think about how this sort of retail transition is being framed. And I'll come back to that framing a little bit later, how it's framed by business and how it's framed by government, and what its impacts on food security and nutrition actually might be. This is not the only place of change. So we've been looking at kind of what's happening in retail at the local level, at the neighborhood level, and mapping out food retail in different neighborhoods. And the map here is of Philippi Ward 34 in Philippi. And you can just see the proliferation of food retail. And these questions about, well, what is being sold and why are people consuming what they're consuming and why are things located where they are? So kind of in the bottom center of the map, there's a real agglomeration, and that's where the train station and taxi rank are. And so there's something about people's mobility and their ability to buy food on the way home from commutes. Around the top right, the northeast, or whatever we're going to call it, there's a proliferation of fresh produce traders. Those are sitting directly outside the supermarket. So there's these kind of relationships between supermarkets and trade. Now we can talk about whether this kind of food retail is health promoting or health demoting, I guess. But I think it's important to recognize that this remains an important component of the food system. And not only that, but in many ways, it is under the control of local government. And there are many interventions that local government can make that would perhaps crowd healthier foods into these environments. So just a few slides from a great master's thesis by Robin Park Ross, in which she looked at the Belleville taxi rank and where traders were. And this kind of red blocks show where all the traders were. And just here where the yellow arrow is pointing, you can see that there is a set of trading bays that have been set up by the city that nobody's using. And so it seems that sometimes when the city does try to intervene and provide trading opportunities for food retailers, they don't quite get it right. And so, you know, when Robin was talking to the traders, they identified a number of problems around crime, around poorly located and inappropriate range of trading spaces, around lack of appropriate, safe and affordable storage, problems of water, sanitation, waste removal. And when you look at those things and you think about how that then shapes what people are able to sell, well, then you're going to see a higher proliferation of highly processed foods that don't require a lot of preparation, that don't require a lot of refrigeration or storage. And so we've got to think about, well, if the city does have this capacity to provide trading spaces, to manage informal trading, and to think about the kind of infrastructure that might be enabling of creating a healthy food environment. Because what we see, and this is from the inside of a spaza in Masiphumelele, where we're currently working, we're seeing that the food system that's being reflected is dominated by the large food brands. The other picture shows a Coke truck sort of going through the streets. And what we're seeing is that those big food companies, who are often selling ultra-processed foods, high in sugars, high in fats, that are generally, you know, not great for our diets, they are able to get into every spaza and every street when municipalities can't provide water. And so, you know, where is the relative power in the food system, and where does power need to be regulated, and where do things need to be enabled to allow a more healthier food environment to determine? Because what we've seen is that decision makers are often fundamentally reshaping the food system, but have absolutely no awareness of the food system outcomes of this. And so you look at the rhetoric around mall development, and it's about job creation. It's about creating a modern retail environment. It's about brand identity. It's about kind of the capital flow that comes in from the infrastructure development. It's not about food. Likewise, we've seen informal trader policies that make absolutely no mention of food, and there's no thinking about the kinds of foods that might be sold by the traders and how you might be able to intervene. And these are all things that fall within municipal mandates. And so they're all things that municipalities could act on if they were to adopt a kind of a food sensitive lens. We see transport planning that doesn't consider food and mobility interactions. So you see a new taxi rank being built with no trader bays allocated to it, or no trader bays with any kind of meaningful infrastructure. And then there's this kind of, well, and how do people live, move, and have their beings in these spaces? What about delivery, design, and maintenance of critical infrastructure? So right now we're doing remote field work in Masi, and we're talking to people about just these things, and how do the food environment and the infrastructure environment and social services all interact to shape how people feed themselves and their families? You know, what does it mean when the cost of electricity is exorbitantly high, or you're connecting illegally? What does it mean when LPG suddenly becomes unavailable? You know, we've seen people only cooking meals in winter because then they can also use the heat generated to heat their houses. And that makes economic sense. What does it mean when the tap runs out of water at 8 a.m.? How does that then shape what you do with your food? What about the quality of housing? And so our argument has been that in all of these things that intersect, they all shape the food environment that people occupy, but also their ability to purchase and use that food effectively. And so national scale policies really need to be integrated with local scale policies and programs to achieve impact. There's no point in having a soda tax if you're not understanding why it is that those soda companies are able to penetrate those markets and why it is that people would rather buy Coke than drink water when the water's unsafe. We need to work with existing mandates of local government to increase food sensitivity in planning and programming. I've done some work on this, and there's been work done at the Dullah Omar Institute as well, looking at those mandates and seeing how many things intersect with the food system and how many points of leverage there actually are to make changes. And I think the opportunity is now, because I think COVID has revealed just how little we understand of our food system and how vulnerable our food systems are, and also how costly NCDs are to us as a society. And so, I think food system policies can be central as we seek to rebuild our economies and to improve public health. And the levers are there, and they can be quite powerful. But I think if we're moving forward, and we've got to recognize that we're in a period of austerity, and governments have a shrinking purse, and NGOs have a shrinking purse, and civil society has a shrinking purse, there's going to be a need for governments to work transversely within themselves, so different departments working together, because none of this is going to work in a silo, but also find ways for government, civil society, NGOs, and dare I say it, the private sector to work together to address food environments and the lives of people that are shaping NCD outcomes. Thank you. I'm done.
Thank you so much, Dr. Battersby, for a really interesting presentation. I've no doubt you'll get some questions in the Q&A, and I think, it all stood out to me, but particularly the mention of power in the food system and no awareness of food system outcomes, and frankly no interest in it either. But thank you so much. And if you'll allow me to please welcome our third and final speaker, Dr. Vicki Pinkney-Atkinson, who is the director of the South African Non-Communicable Diseases Alliance. She's an activist for equitable healthcare and is living with more than 20 NCDs herself. Doc, you have 15 minutes to take us through your presentation. The floor is yours.
Thank you. Can you see the screen?
We can, thanks.
Thank you. So hi, thank you very much. I'm really impressed by the previous speakers, Jane and Rina, because you have really done the perfect introduction for what I need I'm going to talk to right now. And it's an honor to be here because so often NCDs have been omitted in the last 20 years. And so we're looking at human rights and NCDs and the link between safe and nutritious food at NCDs in South Africa. Oops. Sorry, I don't know why it's going. Sorry about that. It took a huge leap for mankind. So the South African NCD Alliance was formed in 2013. It's a virtual alliance between Diabetes South Africa, Heart and Stroke Foundation, Cancer and Pango. And we rose out of an NGO called Pango, which had really no focus. And it's no good being a patient group unless you know what you're doing. And if we can't oppose the formation of Pango, it was of the NCD Alliance, it was against the great successes of the HIV and AIDS movement and treatment action campaign. And we were really floundering as a group to get any traction on the issue of NCDs. And what we really wanted was accountability. And why did we become a virtual alliance? Well, a virtual alliance. There are so many NGOs that start up and fail within 5 years. It was really quite silly to do it all over again. And what is our why? We want equitable access to NCDs plus prevention and management. This NCDs plus is very vital to us because we are trying to reframe the way in which we have, in terms of the MDG strategies, how we have made the whole world into a series of silos of diseases. NCDs plus deals with primary prevention right through to the end, and it deals with risk factors, it deals with conditions, and it deals with other linked issues such as disability. So we're looking for equitable access to NCDs prevention and management within the SDG agenda, which includes UHC, not the NHI we've got, which is just a financial model. And what we learned along the way was to use policy advocacy and coherence as the foundation for what we were doing. And how did we, well, we started with this little report. We got some grant funding. As you know, funding for NCDs and any NCDs project is minimal unless you happen to be in one of the chosen topics. And so this report showed very clearly that NCDs policy, when it went to a provincial level, was non-existent. All the red shows there were no policies and no budgets for NCDs. There were draft policies in a few places, but none of them, I can tell you, many years later, only the Western Cape is beginning to implement an NCDs related policy, I think particularly for diabetes. This was our report that we did, and we did it benchmarking it against the Global Action Plan criteria for NCDs. When we go through the budgets and the way in which money is treated for NCDs in the Department of Health, the ratio of funding of NCDs to communicable diseases is well, if you do it communicable to NCDs, it's 97:1. And the same kind of picture goes for the way in which civil society organizations are funded. This is the kind of funding that goes for the HIV and TB funding. Of course, it includes conditional grants, but here we have the tiny, just about over R1 million that goes into civil society organizations. We have learned to do all of this along the way by making lots of mistakes and learning to do things differently. Where we've got to today by learning about policy, coherence, and equity for NCDs plus, and we benchmarked our equity, call for equity, against the MGG's program for HIV and TB. Today, we have a case before the Human Rights Commission for equity for NCDs policy and policy coherence before COVID, during COVID, and after COVID. There are gross inequities, as already been noted. We used as a way that we got into this was looking at health policy, because really the only thing that is vaguely measurable is the policy itself, not necessarily anything on which the policy is founded. So the National Department of Health has put out successive strategic plans, which in many ways, are absolutely catastrophic for NCDs. They have never been implemented. There are no plans that go down to provincial levels, and there is no funding. And so we have successfully stopped with a group of activists, 100 groups that we work with. We have successfully stymied the completion of the National Strategic Plan for about 4 years. And that was strategically done until we got a case before the Human Rights Commission. We don't have the funding of the AIDS community, and so therefore it has to be done in a very strategic way. We also have taken on the National Development Plan, which actually only looks at primary prevention, and even though it notes and has 2 priorities in health, NHI and HIV. The only other priority they've recently added, which is not in the health channel, but in the social development channel, is disabilities. They note that NCDs are a growing burden of disease, but have yet to make them a priority. Retrospectively, we learned to look at a way of policy change, and we used Kingdom's multiple streams approach and found this to really, with adaptations, to make it work. There was no way when we started working on this policy, which actually I now look back, dates back to 2007, that we were going to make any inroads while the focus was only on two issues, that is NHI and HIV and AIDS. And the policy window was firmly shut, and there were the most extraordinary, and still continue to this day, the most extraordinary issues to keep us silent or not give us a voice at all. The policy window cracked open when Motsoaledi was replaced as Minister of Health. And while we have still yet to receive a response from the Ministry of Health, we have made deposition after deposition and now have a case before the Human Rights Commission. And so the policy window flew open, I hate to say it, but with COVID. COVID has proved to be the one time that we are finally beginning to be heard. This is, as it's been alluded to, let's not beat around the bush. The blue line is NCDs. I know that Rina did it in a different format, but this is the leading cause of death in South Africa, and the leading cause of death amongst women happens to be diabetes mellitus. If we added, as has been suggested by Public Health England, NCDs and violence together because they are all non-infectious, we should probably come up with the biggest cause of mortality. Is this reflected in the budgets? Is it reflected in policy? Not a chance. We have been I grew up in the primary healthcare era. The Millennium Development Goals, while they may have been great for HIV and AIDS, they were catastrophic for NCDs and other conditions. And now we hope that we look to the SDGs for a better way forward. This slide shows you a different one from what Rina, she used the ones from Priceless showing the little circles. I did a tree diagram, which just shows you the green is NCDs, hypertension is here, diabetes is here, heart and renal, and these I contend are all of the same metabolic category. What is missing from here is obesity because the data wasn't collected. And it is showing to be, obesity is being shown to be one of the strongest links to morbidity. HIV and TB are important, but not nearly as important as HIV and AIDS. I guess it depends what you've got. Dr. Tedros has said we can't go back to the same thing that we've had in the past. It's like Einstein saying, we really can't keep doing the same thing over and over again. It's insanity. So we need a paradigm shift for chronic illness, and that's what we're asking for. The paradigm shift comes in the form of doing away with silos, and boy, do we love silos. We've got to end poverty, economic, and these are all of the SDGs that are related to NCDs. You can see it's improved nutrition. We don't believe there's one solution. It's about a holistic approach. We believe that one of the things that we can take on together that would actually reflect the problems in our health system would be obesity, and obesity as a condition, not just as a risk factor. As it was noted by Jane, obesity, and I think Rina, obesity is not just a lifestyle issue. I want to get very ill when I hear it being called a lifestyle. It's like the rich and famous. It's absolute nonsense. It's a complicated illness. What COVID is showing to us that there are biological factors. It is probably the leading cause globally of morbidity and mortality from COVID. Its impact is that you get COVID sooner, you get ill sooner, and you are more likely to die from obesity. Do we collect statistics on it? No. That's a terrible tragedy. And this is the same one that in the same group of slides that came out of the health promotion levy. I'd like to suggest that if we're going to do anything differently, we've got to change the way in which we approach health policy. For those of us who are people living with NCDs, this looks like a wonderful advert for a policy, but it was really one of the most flawed issues that I've ever seen. People with living with NCDs were not included in this particular policy. It was all done by academic research groups behind the scenes. We had to fight our way in. We were told to get out of the space because who were we to talk about NCDs? This was really about economics and not about diabetes and losing legs and things like that. And so the whole process, which we eventually got involved in, is, I'm suggesting, not the way to go on any future policies. I also agree with Jane that this was so much money was thrown at this, so much time and effort was thrown at this particular policy when we failed to deal with the systemic problems related to obesity in our society. And I would like to suggest that we find different ways forward to deal with obesity. Whole organizations were set up in this period. A whole organization was set up so to deal just with being a support organization when there were bona fide organizations existing in the community. I suggest we have to have a greater grip on what we do in the future. Sorry, last slide. Believe it or not, we also go for global nutrition targets, and we can see we're failing dismally when it comes to South African on targets. When we look on, and those are from the global nutrition plan targets in 2019. When we look at the indicators, South Africa, a lot of this I would suggest is hogwash, because we don't actually have the data to support most of these things. And when it comes to food reduction, we only look at very small amounts of number of issues. We have to hold our government accountable. Where did the money from the sugar tax go? It did not go into primary prevention. It did not go into health promotion. I believe it is 100 million rand went into cancer treatment at a tertiary level. We have to hold government accountable for its failure to deliver any policy, any interventions for NCDs, and the thing that kills most people, including those people with HIV and AIDS. I ask that we work together and find a way forward, and we have to stop what can be prevented and have a better society for all of our people. Thank you.
Thank you so much, Dr. Vicki, for your presentation. Really interesting, and you mentioned it enough times that you can't talk about policy without considering budgets and accountability, and we'll get to the Q&A soon. I just want to thank all three of our panelists for a really good presentation. And if you'll allow me, we are good for time. So I'll dive straight into the Q&A. So the first question I can see, which is from Marcia, apologies I'm not pronouncing it correctly, is, with obesity now being identified as disease, what does this mean for people who struggle with weight issues, but never been diagnosed to be living with obesity? It's not directed at anyone, so if any of the panelists want to take a first stab at that question, please go ahead.
I would, hello, it's Vicki here. I can tell you about that because I lived with obesity for a great deal of time. And I mean, I don't think obesity is hard to diagnose. It's one of those things why you can throw stigma at it, because you can see, if you're talking about BMI over 25, it's something you can see. And so I've lost 41 kilograms. And I didn't actually do anything much to lose the weight in the end. It turned out to be the condition, the illness, the stress, all of those roots that you're talking about. And it has to be, our policy on obesity talks only about never treating it as anything more than illness that requires good nutrition and a bit of exercise and some knowledge. It's much more complicated than that. And so I think we've got to treat it in a holistic way, and we've got to put together things like diabetes. We've got to put hypertension together. We've got to put all the cardiovascular, and we've got to treat obesity as one illness. And that's what the Lancet review recommended at least 3 years ago. Thank you.
Thanks, Doc. Prof. Swart or Dr. Battersby, would you like to comment on that question?
Maybe, but I just need to, what I want to re-emphasize again, I think Vicki is quite right. It needs to be comprehensive. It needs to be, to look at the complexities associated with it. One of those, or some of those complexities are linked to early interventions and awareness of challenges. And again, if I may say, the prevention component, it is better to prevent it than only try to treat it. So I do think we need to start at different, approach the problem, not only as one that needs to be treated or wait till it needs to be treated. It needs to come from different angles.
Thanks, Prof. If I may, the next question. Will the presenters please comment on the use of commercial baby food, availability, consumption, and then specifically for Prof. Swart, the sugar content?
I can respond to that, and I will post a link to a paper that was done where some analysis was done on baby food available at that time on the market. And it is true that the sugar content of baby foods is much higher than what is desirable. We need to remember that sweetness and even salty tastes are learned tastes. So the earlier you introduce a person, a young baby, to those tastes, the more they will acquire the taste. So really, I mean, there are different strategies, different suggestions as to what the levels, acceptable levels would be. But my recommendation would be that we need to, one, try and rethink whether commercial baby foods are necessary. Chantel made the comment online about breastfeeding, and that is an excellent starting point. That's where part of the prevention of obesity starts. And so we do need to look at what types of food we use as complementary foods for babies. It again is complex because it is about time for preparation, energy for preparation, and all of that. So it's very convenient to have commercial baby foods. But should we choose to use commercial baby foods, we need to then request, vote, ask, demonstrate to have those foods not sweetened to our tastes, but keep it without the sugar and without the salt, because babies do not need that at that time.
Yeah, can I come in on this as well?
Sure, of course.
Yeah, so I think there's a lot of discussion about why our breastfeeding rates in South Africa are so incredibly low. And I think we have to recognize the damage done during the HIV years, where very mixed messages were sent around the safety of breastfeeding and how that's kind of undermined things. We also need to recognize that the advertising of particularly infant formula is not permissible, but Katie Pereira, who was on the call but has since left, she recently had a paper out just showing how the manufacturers are able to sort of bypass that. And so there is still kind of quite strong marketing of those products. And so I think it comes down to health information. It comes down to what's being made available in the market. But there's also, wider social processes. And so Western Cape government have been trying to do a kind of breastfeeding promotion program. but there's other barriers in place. We were talking as a small group just the other week about, you know, the way in which one of the things that men will pay for is formula. And therefore there's kind of an incentive for women to keep their children on formula as long as possible in order to make sure there's still money coming into the system. So there's a lot of reasons why this is in place. And again, it comes down to really understanding the system, but recognizing that we are in a really difficult position where those infant formulas are really flooding the market, and the follow-on formulas in particular are gaining traction, and it does need stronger regulation. Thanks.
Thanks so much, Doc. I mean, that's a really interesting point to consider. If you'll allow me to go into the next question, which I also it also crossed my mind. It's from Andrew, and it is, why is there almost 2 times the overweight and obesity regarding women as compared to men in South Africa? Again, any one of the panelists can go ahead if they want.
I think there are many reasons. I'll just offer one, and please, I hope the other panelists will add to that. There are certain norms that definitely contribute to a well-rounded figure being an acceptable figure and actually being an illustration within social context of well-being even, or economic wellness of a household, a family, a man. And to some extent that influences how we behave and how we act. That's just one of a very complex set of factors.
Thanks, Prof. Dr. Battersby, if you maybe want to give some context as to the food environment that women maybe find themselves in South Africa.
You know, we haven't, I wouldn't be confident in making any particular claims out of that. I think that there are ways in which the kind of relatively sedentary nature of women might play into things. There are ways in which the fact that women will ensure that other family members get fed first. I think all those things come into it, but I wouldn't be confident in making a claim about that percentage.
Thank you so much. Yeah, very interesting point to consider. If I can move on to the next question. What is the role, sorry, this is directed to Prof. Swart. What is the role of dietitian in preventing NCDs? Can employing more dietitians in key positions assist with reducing obesogenic environments? Thank you.
I think the question is here phrased specifically with regards to dietitians. I would like to make it even wider and say health professionals in general, because every professional has got a role to play, and it is important. And if we look at the resources made available to nutrition specifically, we know that the human resources are inadequate to deal with all of the challenges within the system. And I'm not talking only about obesity, I'm talking about nutrition problems in general. But they are so interlinked that the one leads to the other one. So yes, there are not enough human resources within nutrition, neither do I think, and I think Vicki demonstrated that as well, that sufficient resources are allocated to non-communicable diseases in general. And I think that should be reconsidered, how the resources are allocated.
Thanks, Prof. The next question, which is regarding the budget, with the health budget shrinking, how can we advocate for increased resources towards addressing NCDs? are NCDs considered enough of a priority to ensure that resources are directed accordingly?
Hi, it's Vicki speaking. I think it's a great question. I think we've got to look at the way in which we have structured the health budgets, and that was fundamentally changed when we had the HIV era and the Global Fund for HIV and AIDS came through. For years, we lived, and we continue still to be living off large amounts of donor funding for HIV and AIDS, and it's reflected in the national budgets as ring-fenced budgets. And those go directly and are administered through a system from the national level down through the provinces. The same is not true for NCDs. They are all administered through provincial budgets, the equitable share. And I believe that that is a fundamental problem, because nowhere are NCDs actually line items in provincial budgets. So we have to do a fundamental rethink about the way in which we fund NCDs, and the hope for that perhaps lies in NHI, but only if NHI is reframed in a way in which we are looking about the priorities that are for health in the country. And at present, the only priority stated again and again in policy are the communicable diseases, the MDG illnesses. And so it means that NHI, which is only a financial model, has to prioritize the things that are important to people and that are killing the most people. And so we've had great success by treating HIV and AIDS. So we have to reframe and restructure how we look at things. Yes, we can't make money out of air, but we can do things better. And that's really what we have to look at, is how we split our budgets and how they're implemented. Thank you.
Yeah, I think also we just haven't factored in the cost of NCDs effectively enough. So the other year, the Western Cape provincial government did a kind of a back of the envelope thing on costing the double burden in the Western Cape. And they said, they stand to lose 375 billion of household spending from stunting and up to 590 billion from obesity to 2040, which translates to a 5% loss to GDP from foregone spending alone. And I think when you start to factor in the real costs of the NCD burden, that might affect a change and a recognition that actually every rand you spend saves many more.
If I can just add again to that's perfectly true. I think Karen Hoffman did some costing, and globally it's been proven that it's been known for years. And it's not a surprise, but diabetes has so many ramifications in terms of blindness, losing legs, kidney failure, the same for hypertension, and they're all part of the same grouping. So yes, the problem is that most of our costing models deal with individual diseases and they don't put together groups of illnesses, which I think we need for the future. And then just to go back about what Rina spoke about was about healthcare professionals. I am a registered nurse with a PhD, but I also was I was a pioneer of nurses working in hypertension and diabetes in ambulatory settings. And for me, that was in the primary healthcare era. And so for me, it is about all of us going back to those more holistic roots. And it's not just about one illness. We have to have this interdisciplinary way of dealing with issues. We can have super specialists, but we've got to tackle the problems themselves rather than having our silos of being this kind of professional or that kind of professional. And I'd like us to one day consider that as being a vital component. Thank you.
Thank you so much for those insights. Dr. Battersby, if you'll allow me, the two questions directed to you, so I'll just read them in tandem. The there's one comment on where you mentioned that we need to work with the existing mandates of local government to increase food sensitivity in planning and programming. There's a question on whether this has been attempted, and if so, whether an example can be shared. And then another question also to you, Doc, is the role that the school nutrition program could play in increasing food sensitivity.
Great, thank you. Yeah, so this is an emerging area, and so there's a lot of interest in urban food governance at the moment, and many new networks emerging. So I think this is a moment to look at what's going on out there. So the longest running example has been Belo Horizonte in Brazil, which has run an amazing kind of integrated food system for many years. But just this week, Bristol in the UK became the first city outside of London to restrict junk food advertising. So recognizing there are, one of the municipal mandates that we have in South Africa is billboards. Could control of billboards actually be a way to affect kind of this aspiration to have junk food, etc. But if you go onto the website of the Milan Urban Food Policy Pact, and there's a list of, I think, 50 or 60 examples of good practice and lessons that have been learned from those. The World Bank has just released 2 reports about urban food governance. So there's a lot of energy around this, and there's a lot of networks. So I know that ICLEI, World Bank, the FAO, RUAF, Milan Urban Food Policy Pact are all kind of working on this. And so there's a lot of energy for partnerships, C40 as well. I saw there was a bit of a back and forth in the questions about, well, our local governments are so stretched and undercapacitated anyway. Is adding this on really going to be helpful? I mean, this is obviously my passion project, but I think we have to if we're going to see any movement towards good health. And I think it also potentially has many positive impacts on local economies, local sustainability, etc. But there does need to be capacitation, which is why I mentioned these networks, because it might be possible to draw on those, and also the invocation of SALGA. And I think there are people at UWC within the Centre of Excellence on Food Policy working directly with SALGA on this. So I think there's this recognition that it's an important space, but it's a hard space to operate in. And it really does take political will, and also, I think, recognition from national government, and therefore some kind of support, because at the moment there really isn't. The question on the school curriculum, I don't know so much about the school curricula, but I know that the school feeding schemes attempt to provide nutritious food, but I think Chantal will possibly say they're not achieving that. What I have written about in the past is that there's a tension between what's kind of technically in the life skills, life orientation program that gives very basic kind of nutrition knowledge, and the kinds of guidance that goes out with the school feeding schemes, and then the fact that tuck shops are run by the school governing bodies that are not aligned and not affected by Department of Education mandates, and are there to try and sell whatever sells. And therefore, kind of the school encourages you to go to the tuck shop to spend money because it goes into the coffers of the school, but it also is therefore effectively telling kids to go and buy junk. You also got to look at the kind of, again, the sponsorship that schools get, the school signage that's normally provided by a large food company or a large restaurant, and ask about what messaging is being undermined by the messaging that's paid for. Okay, I'm done.
Thank you for that, Dr. Vicki, I see your hand is raised. Did you want to come in?
Yes, I thought that the question also spoke about the integrated school health program. And the integrated school health program as a policy should be the backbone which we are using if we can get it implemented and tweaked. It is slightly out of date. It needs to be revitalized in terms of our current, but the integrated school health policy is a cooperative venture between the Department of Education and the Department of Health. And we really need to get these collaborative programs to work properly and integrated, and not just focus on undernutrition, but overnutrition and a whole building of the life. So for a colleague of mine, Fran Matthys, she was she died last year in a car accident, and Fran was absolutely heartsore that in her lifetime that she never saw the integrated school health policy as a cornerstone of our promotive and preventive health strategies implemented properly. So I do that in honor of her today. Thank you.
Thank you for that, Doc, and I'm sure Fran would appreciate that. If you'll allow me, it's also a broad question, but I think it would be interesting to get each panelist sort of perspective. There's a question on why is the government so focused on communicable diseases when more South Africans die of NCDs? If you have a comment, please go ahead.
I don't think I have worked, well, I might not know everything and not be qualified to answer. One reason I definitely think has been the international agenda to some extent that has driven the HIV scenario. That's one of the reasons that I think could be, and it went with funding that came in for that particular aspect. There might be several other reasons.
If I can add to what Rina's just said, it is and was a terrible catastrophe that struck the world, and that cannot be denied. And in fact, I worked in the Medical Association at that time. It was a struggle to get the policy changed in the 1980s and 1990s. And so it was a terrible catastrophe. And that is why our life expectancy went down to one of the worst in the world, because so many people and so many young people and babies were dying. So it was a terrible catastrophe. Then in South Africa, added to that, we have to remember the AIDS denialism of the Mbeki era. And that certainly did not help anything. And then we had a political, you also have to look, this is part of all of my policy analysis, but you also have to look at the whole movements in that period of time that had to force action on getting drug treatment, et cetera, et cetera. Remember, it was garlic and whatever it was. So I'm putting my foot in and saying it's about political policy. And although it was never stated on the Zuma agenda, that from Polokwane, the agenda became NHI, and guys, underneath that was also coming, beneath that was an HIV policy. And those are the two policies that remain in structure, in government, in the way the Department of Health, in the way the budgets are run, in addition to all the international and global funding. And that has shaped and changed, and I believe it has really problematically distorted our health system today. Those are factual, I believe, statements that can be proven. Thank you.
Thanks, Prof. There's a question, I think it's directed more to Prof. Swart, regarding animal protein consumption and the increase thereof, which would also reflect a similar increase in saturated fat intake. If you'd want to give a quick comment on that, Prof. Swart.
It's absolutely correct. Our animal protein sources are in general high in saturated fat, and saturated fat is one of the nutrients of concern with regards to non-communicable diseases.
Thank you for that, Prof. There's a question on what can we do practically to increase exclusive breastfeeding rates in our programs. Despite information and education, women still prefer formula and other traditional feeding methods. I think Dr. Battersby, you commented on that as well. If you'd like to come in again, or any of the other panelists, please go ahead.
think I'll pass over to Rina. Sorry, Rina, if I throw you into this one.
It sounds like my answer to everything is that it's complicated, and it is. In terms of breastfeeding and why it's not a choice, and I think we've got experts on, as part of the audience who have spent quite a lot of time. Chantal has just recently completed her PhD with the focus of breastfeeding and the challenges to breastfeeding by women. She's made a comment about that we do not really promote breastfeeding in the sense of looking at the nutrition of women when they are pregnant. And that should also be included. One aspect I would like to mention is, again, the era of commercialization, and it takes a long time to undo what has been done. I mean, during the HIV period, there were several questions around safety, and that was exploited very efficiently in terms of breast milk substitutes and the marketing of that. Regulation then clamped down on marketing, but that does not necessarily discourage companies to still continue promoting. And then there are some social normative issues which Jane also referred to, such as men are willing to contribute to infant formula. It's a tangible contribution they can make. Whereas, food for the women is not necessarily a tangible contribution in their view towards the baby. So again, it's complicated issues, and it might have different angles in different communities depending on what the setting and the beliefs are.
Thank you so much for those insights, Prof. There's a few comments on an interesting topic, and I'll sort of join them together. Can stress also be a cause of obesity, especially for women who are now juggling work, home, and children? And there's a comment, without social support. And then added to that, when you look at the body positivity movement and how it encourages mostly women to accept their bodies as they are, how practical is it to highlight the issue of obesity as a condition while ensuring that women don't feel ashamed or pressured to be a certain weight? If any of the panelists have a comment, please go ahead.
Hello, it's Vicki here. I work with the World Obesity Foundation as well. And part of when I put the slides up, I spoke about the complex issue of roots, and that it's not just about one thing or another. As Rina has said, it's complicated. It's very complicated. And from the time that women are young, they are told, given messages about how they should look. And it's not just stigma in relation to HIV and AIDS, it's stigma about many things. It's stigma about how you look, how the shaming of women. So we've got to reframe it that your body is your body, but you can do something about it. It's not to reject your body, because then it's a whole complicated set of messages and support that we need to do. It's not just an ugly uncle or a boyfriend or somebody who's going to give you a bad vibes about what you look. Have you ever listened to how health professionals speak to people who are obese and overweight? It's horrendous. And so it's a complicated story. It is about stress. It's about a whole lot of things, but we have to start with saying it's a problem, it's a condition. How can we move forward? And then we will have to work beyond that. Thank you.
Thanks, Doc. We are sort of heading to the end of the session, but if you'd allow me to take a few more questions, because I think there's some really important ones. and then my colleague will wrap up. But if I may go ahead, there's a question stating, in my country, Uganda, some of these NCDs are more prevalent in the higher socioeconomic groups. I don't know if this is different in South Africa. And the question is, how do we start advocacy in the midst of poverty-related ill health? I'm not sure if Dr. Vicki, you'd want to go ahead and tackle that question.
I think, well, it's really hard. And yes, but it's not only with socioeconomic status. I think what everybody has, it's not just a disease of lifestyle and being rich and lazy and fat. It's also about where you get cheap sources of food, obesogenic diets. It's much more than that. So how do we start? We have to acknowledge the problem is more than just a behavioral problem. And that's how often it just gets framed. You've just got to eat better. As Jane has spoken about our urban environments, it's about how do we get our exercise? What is the messaging? You've got to go to a gym to get exercise. There are just so many different ways, and it's all about lifestyle. You know, it's got the wrong messaging. So number one, we need to acknowledge that it's a problem, and then we need to move forward collectively to change, whether it's legislation on food packaging or food gardens or whatever it is. We have to move together, and it's not just a government job. Communities can start to do it if they're resourced adequately, just the same way as the HIV communities managed to do it for HIV and AIDS. Thank you.
Yeah, can I leap in very quickly? I mean, I think we need to acknowledge, particularly since this is a Dullah Omar Institute seminar, that in South Africa we have the right to food, and it's a right that has not been mobilized, it has a right that has not been tested. And I think that there is increasing mobilization around food, and we're seeing, you know, there's a group of a kind of a farmer research collective operating in the Cape Flats now who are trying to think about, well, how do we do that community scale mobilization? How do we do that exercise of rights? Because the latest framing of food security from the FAO has added agency as one of the now 6 pillars of food security. How do we increase that agency? And I, you know, we hate to make opportunity out of a tragedy, but it does seem that this COVID moment has prompted people to a lot of anger and a lot of revealing of the things that are wrong in the food system. And it's also re-energized a lot of community networks. And so I think now is the moment to think about how that community mobilization takes the way forward, and how to get people conscientized around the right to food and the right to health.
Thank you for that, Dr. Battersby. These questions are actually directed to you as well, and I'll sort of join them just in the interest of time. If everyone could bear with me for a few more minutes. With the evacuated cities and change in working practices, is there any discussion on urban planning, talking to landlords on transforming the space with community gardens or growing rooms in mind? And then linked to that, municipalities should make it compulsory for the property industry to build open spaces for creative space when undertaking urban development. If you could just give a quick comment on that as well, please, Doc.
Yeah, I mean, so I mean, obviously we saw in places like Detroit with the massive economic collapse that the vacant lots were turned into agricultural projects. And I think, you know, we've been saying for a while that there's a need to do an audit of land that's available for urban food production. And I think it is a critical component that's not that well understood, and the barriers of access to land are complex. And so I think there is a need to focus a little bit more on that. On the question of developers, I'm not sure I've entirely got the gist, but one of the ideas that we've been trying to play around with is the idea of, you know, how when you do a new development, you have to have an EIA, an environmental impact assessment, and sometimes a transport impact assessment, and sometimes a heritage impact assessment. Perhaps now is the time to push for a food impact assessment, and people would have to demonstrate how they are going to impact the food system positively or negatively in order for their development to be granted developer rights. It's an idea we're playing with.
Yeah, I would support that idea, suggestion by Jane, because I do think it is usually the last thought on anybody's mind around what food could be produced, has been produced, should be produced. Not only when developments are being planned, but often it is more about, I almost want to say quick cash, and not necessarily for the nutritional value of what will be produced.
Thanks, Prof. Swart. I see quite a few comments, but we don't have time for them all. If you'll allow me the last question, and if each panelist could respond and in 1 minute, just say their final comments. And the question is, health problems are lifestyle related when in fact they are systemic. In what way could civil society organizations promote change from the bottom without reproducing this narrative? In any order, if you could just give your last comment. Thanks so much.
It was an easy question to finish, why don't you? Yeah, I mean, I think it is, look, there's a lot of things going on around the world that people are trying, and I think it's worth looking to see how that mobilization has happened elsewhere. There's examples from the global north and the global south, and I think rather than just trying to pluck ideas out of the air, let's see what's working elsewhere and think about how it can be applied to here.
Thanks, Doc. Prof. Swart, you can go ahead.
Yes, I think addressing systemic issues is difficult, but it is a conversation that should start with everybody identifying. And I think when you frame the child or children as the future of the country, as the central point, then that makes the conversation slightly easier. So I would suggest that we do find common issues of concern and then begin to untangle what are the contributions and look at what worked elsewhere, and how we can implement this. The worst thing we can do is sit and wait for somebody else to do something about it.
Thanks, Prof. Dr. Vicki, if you want to give your last comment.
Well, thank you for having me, and thank you for talking about NCDs. It's a great relief to hear it finally talked about. Thank you. So I think one of the issues and why we're involved in advocacy is that we believe that policy is not just top down, which is how it normally happens in our country. It's got to be bottom up, and it's got to be based in grassroots. And I hear what is being said about examples from elsewhere, but we have such an infrastructure that was put in place around HIV and AIDS, and many bodies and organizations, that we need to begin to shift the emphasis, whether it's around children or around the elderly who look after children. It's got to be done based on the communities in which we find those people working. There is a policy going on at the moment which frames a lot of what goes on in healthcare. It's called the integrated person-centered healthcare model. And so it's really putting together not just one part of us, but our whole body and our whole health. And I think that's where the SDGs are different. So take overseas examples, but build on what we've got. We have got in some places marvelous community infrastructure. Thank you.
Thank you so much, Doc. And thank you to all three of our panelists for a really interesting webinar. We often, run out of time when the discussions are so interesting, but there are more webinars to come. If you'll allow me to hand over to my colleague Gladys to do the final closing remarks. Thank you.
Thank you, Paula. I'll be brief. I want to thank all the participants for joining us in this important conversation, for making time to engage with the panelists. We really appreciate. To the panelists, thank you for sharing your knowledge and important information, for breaking down this complex topic, and for flagging issues that we as stakeholders were able to engage with. All panelists emphasized on the need for a paradigm shift in approaching NCDs. Professor Rina Swart, thank you for setting the scene on the extent of diet-related NCDs in South Africa and how vulnerable our food systems are. Dr. Jane, thank you for sharing examples of good practice of urban food governance and for helping us reframe the narrative of the nexus between changing diet, the national NCDs, and burden disease profile, as well as linking that with the rapid increase of supermarkets close to where we live. The third panelist, Dr. Vicki, thank you so very much for doing a great work engaging with public health budgets and process systems. We look forward to the outcome of your engagement with South Africa Human Rights Commission on the policy coherence and equity for NCDs against benchmark and MDGs. Thank you also for reminding us how food systems are linked to community mobilization and that they're central to improving public health post the COVID pandemic. We really appreciate your time and appreciate the knowledge. I think you'd all agree with me that this has been a very informative session. Please keep an eye out for an upcoming webinar in this series on NCDs. And with this, I want to thank so very much the Dullah Omar Institute, the technical team behind setting up this webinar, Kay, Sapto, thank you so very much. And also the team leader here, Professor Durojai, as well as Paula Knipe for anchoring today's meeting. And with those few remarks, I want to thank you all for your time, and we look forward to having you next time in this particular platform. Thank you. We've come to the end of this meeting. Thank you very much for your time, and goodbye.
Bye.